have Dr. David Hasan. Dr. Hasan is a professor of neurosurgery, biomedical engineering, and neurology at Duke University. Dr. Hasan is a scientist neurosurgeon with extensive experience in the management of cerebrovascular diseases and skull-based tumors. He is dual trained in cerebrovascular and endovascular training with extensive background of treating over 3,000 brain aneurysms using innovative techniques, including awake surgery. He is an international authority in the cerebrovascular research with over 300 peer-reviewed publications, multiple NIH grants, and he's member of several editorial boards of high-impact medical and surgical journals. We're excited for your talk today, Dr. Hasan, which is titled, Can Aspirin Decrease Risk of Aneurysm Formation and Rupture? Dr. Hasan, please.
Good morning, everybody. It's like 9:30 here, and it's already, we started our grand rounds. But I want to take the opportunity to thank Dr. McDougall and his team for having me this morning. It's quite an honor to be on this list, if you will. Today, mainly, it really is not, I'm going to talk specifically why aspirin or how can aspirin decrease aneurysm rupture or growth. More of really we're going to discuss about the tools that we have developed over the years that anyone can use it to kind of study aneurysms and hopefully advance the research of it. So you guys see my presentation?
You're not sharing yet.
Oh, share. Okay, hold. Let me share. Can you share the?
There we go. Yep.
Okay. So the topic.
Actually, we're seeing your screen, not the presentation.
Okay.
We're seeing your.
I thought we already did it.
I think if you would have opened the presentation, it would have shown up there. But or is
how about now?
Yes, there we go. Perfect.
Okay. So mainly I'm going to talk about how to study aneurysms, and you do it in a comprehensive way. What do I mean by comprehensive way? Meaning using human perspective data, human aneurysm wall tissue, which we harvest after aneurysm clipping. We do also a liquid biopsy where we take blood samples from within the dome of the aneurysm. And with that, we do multi-omics, including genetics, transcriptomes, metabolomics, proteomics, and different things. We're also going to cover some of the imaging techniques that we developed or took advantage of by others and advanced it. And we also can incorporate some of the biomedical engineering, including computational fluid dynamics, finite element analysis. And also we did intra-aneurysmal pressure gradients, and most of all, how to translate that back and forth between animals and humans and validate that. So this is how my journey in the last 16 years, if you will, in understanding the pathophysiology of brain aneurysms. And as you know, at this point, I'm Homer. So there's a lot of way for me to go and continue with my research. Ours is a model of translational, where we see an observation in humans, and then we take it to the animals, we validate it in terms of mechanistic pathway, and then back validate it in humans. So it's kind of back and forth, and why that's the model we use is translational. So I'm again using aspirin as a model of how to study aneurysms in 360-degree. So this goes back to almost when I started 2009. And I was reading an article published by Douglas Chiat, and he was the first to take aneurysm wall tissue and analyze it. And he published that, and he said there was a lot of inflammatory cells within the aneurysm wall. We all thought that the aneurysm wall then is just has no cells whatever, it's just collagen and elastin. But because of that, I made that hypothesis, well, it's truly inflammatory cells, then we can modify that and we can modulate that using an anti-inflammatory inflammatory agent. And that's what was our hypothesis. And we said, okay, we'll use aspirin. And the reason I used aspirin is, you guys have to kind of understand, Iowa was the data center for all the ISUA studies, ISUA 1, 2, 3, and 4. Even though Mayo Clinic was the leading center, Jim Turner was the biostatistician, so all the data was in Iowa. And I went in and looked at all that they have, and in terms of medical agents, they only have aspirin that they listed. And their hypothesis then was aspirin will worsen aneurysm and lead to worse outcome if it ruptures, if you will, or increases rupture, which wasn't the case. But till 18, 19 years later, that's when I made the hypothesis to say, can we look at it in a different angle? And instead of thinking aspirin as a harmful agent, can we think of aspirin as a protective agent? And then we try to think can there be a gender difference in response to aspirin? So this is what we did. This is from ISUA data. It was prospective data, if you will. And if you compare never aspirin to 3 times or more per day, then you have about 60% decreased risk of aneurysm rupture. And that was the confidence interval. So for the first time, we showed that there is a medical or a medication or therapeutic agent that can modulate aneurysms. So the question is that difference between male and female? We all know that it's more common in female, aneurysm more common in females, and aneurysm rupture is also increased in females. So we separated male and female, and behold, we noticed that this effect holds only in male and does not hold in female. You can see right here, it's significantly decreased in male, and female it doesn't. So this was published in Stroke, and Mike Timinaski from Toronto said, no, David, this is not a cause and effect. It is just more an association. People who take aspirin, they tend to be healthier. They take care of their blood pressure. They take a cholesterol. So it's a sequela, if you will. It's not a cause and effect. That made me, and by the way, I never done research before. So because of that, I took on the responsibility, like I'm going to prove that to Mike and show him that it's truly a cause and effect. So, but I start thinking how I'm going to do that. It's impossible to do prospective trial. We try to go to the NIH and we got shot many times. It's like impossible to do a prospective, randomized clinical trial where you randomize patient for aspirin or not, for many reasons. So we start to think creatively how we can prove that. And one of the things we start thinking about is imaging. And you can see right here, this is what I used to do and continue to do, is sometimes we clip aneurysm that are not amenable for coiling, and we cut the aneurysm and send the dome or keep it in our lab and analyze it. And so you can see right here, this is an exaggerated form of aneurysm, completely atherosclerotic, and you can see right there a flip at the base. This is an ICA terminus. That's before the web device, and you can see the atherosclerosis, the yellowish within the wall. And we gram stain these and do multiple studies. This one is from Helsinki, where I did my open vascular fellowship with Hermes Niemi, and you can see they confirmed what Douglas Chiat mentioned about inflammatory cells in the aneurysm wall. And we focus on macrophages, and I will tell you that we spent 5 years looking at it. But the macrophages are the cornerstone of all these inflammatory cells within the wall. So we used an agent, femoxytil, which is a nanoparticle approved by the FDA and to treat anemia. So we use that, and this nanoparticle is only taken by macrophages. So if you can somehow tweak the images, you can the sequences on MRI, then you can really image macrophages within the wall. And that's what we did. We brought patients and we put them in a hotel. We imaged them at time 0, and then we gave them the medication, then immediately, then 24 hours, 72 hours, and then 120 hours, and then clipped their aneurysm and took that dome and looked for these cells. And you can see here, the best image was at 72 hours. And you can see that here, the signal, the black signal, if you will, the hyper intense in the wall. And we validated that, as I said, in the aneurysm wall. We found out that macrophages, like here, and in the top corner on the left, that's the Prussian blue, stains iron. And then in the below is the brown, is CD68 with macrophages. And you can see they're superimposed. And here is my electron microscope. We can see that macrophages take on the blue. This is the one on the right. And you see that. So we did a small study where we randomized patients to aspirin or placebo. We imaged them. We monitored them for 3 months on the medication, and then brought them back, clipped them, then imaged them, then clipped them, and collected the tissue, and looked for that. But before that, we tested it in mice. So we took their monocytes, if you will, and we activated them. And you can see there on the control, when you activate the monocyte, become macrophages, and they take all this femoxytil, if you will. And then if you put them with aspirin, it inhibits all that. So that's what we did here. You can see right here, and this is the slide we published in Stroke, is aspirin decreased the inflammatory cells in COX-2, MBGS, and macrophages. So, and this is, as you see here, it's all significant except for COX-1. So for the first time, we use an imaging technique, if you will, with already approved, commercially available agent that works like gadolinium, which we still use it. We use it in Iowa. We use it here at Duke. A patient has renal failure, or we use it as a contrast agent. And we showed through the tissue that aspirin directly decreased the risk of aneurysm rupture. And since then, there are multiple studies that came around that looked at the frequency, the dose, and the higher the dose, the more effective the medication. But this medication, aspirin, only affected males, not females, if you will. So we decided, okay, well, can we look at the growth and see if aneurysm does change or modify the natural history which aneurysm can grow? And so we looked at my database for over 10 years, which we kept all the aneurysms. And in Iowa, we have the Iowa Medical Center, which covers 3 million, and nowhere else in Iowa does that. So we lose some patients to Mayo and some to WashU. So we looked at almost 2,067 aneurysms, and some of these aneurysms were treated, had multiple aneurysms, and followed them. And the growth was about 10.5% over 5 years, if you will. And what we noticed here is that aspirin is the only agent that decreased the aneurysm growth over 5 years. So all these patients had at least 5 years of follow-up. And then in terms of growth, if you have history of rupture or hypertension or drug abuse or polycystic kidney disease, then the growth is higher in these aneurysms. And then it's like, okay, so can we look, and Dr. McDougall knows that in the beginning when we start, he's the first generation on the second. We only did coiling. We had stent, but we mainly focused on coiling aneurysm. And at that time, we had a lot of recurrence for many reasons, up to 20%. And so I looked at my series, which started in 2009, and the aneurysm we thought got really well coiled. We followed them with time, and we wanted to see if there's a change in terms of medical agents. And you can see here, there was no aspirin, and again, we found that patients who were on aspirin had less recurrence, which also we showed that the recurrence can happen due to two mechanisms, either coil compaction or the actual sac itself elongate or the neck enlarges. So this is, you see right here, again, aspirin in blue, and control was in gray, and you can see here a significant decrease, if you will, with use of aspirin in terms of recurrence. So since that happened, we were very excited. We developed the technique for femoxetol, as I mentioned earlier, but everybody started using it around the world as a tool, and fortunately led to a lot of complications, and the FDA black boxed it, which means you cannot use it outside its indication. So we have to think creatively of how we can move from femoxetol. Again, this is the talk, is kind of have to be adaptive, creative to find ways to continue study aneurysm and advance these techniques, if you will. So by then, the guys in Yale, Charles Matouk, published on vessel wall imaging, and he showed that the aneurysms that's ruptured or tends to rupture, they have wall enhancement, if you will. And we try to use that as a technique, if you will, to continue with our research. But also, Hasan Awad came in with the QSM to study the iron burden in cavernomas. And I helped him in many ways, and if you will, of developing this technique. And we use it in 3T, and we found out that if you use QSM away from the bone and modify it, and we use the 7T in the beginning, you can actually see microhemorrhage that cannot be appreciated on regular MRI or CT, if you will, and image that. And you can see like it's a hammer on the, on a small hat. And we validated that both in tissue, right here, if you will, and other studies. And you can see here in vitro that QSM is perpendicular, is linearly correlate with the iron. So we try to use that in aneurysms, and we developed protocol. We would image MRA with GAD, QSM, vessel wall images. And we use a different technique to quantify the vessel wall imaging. And you can see right here, we're able to show that QSM does match the vessel wall imaging with high sensitivity and specificity. And this is the protocol we developed and used it for many times. But we wanted to validate that in rabbit. So we went to the rabbit with working with the Mayo group, and you could see right here, we showed that vessel wall imaging correlate with macrophages. And so we start, back to histology and use vessel wall imaging to confirm that it's inflammatory. I'm sorry, guys, this thing is moving its own. So what we showed right here, that inflammation I'm going to stop this a second, guys, if possible. It's just moving fast, and it's like automatic for some reason. You can ask me a question, guys, while I'm trying to hair slide.
I was thinking I was just slow trying to keep up. You were going so quick with me there.
I know. I'm sorry.
No, not to worry.
Yeah.
I'm really enjoying the presentation. I love how systematic you have been in sort of the stepwise working through these issues. It really is a great illustration of the sort of tenacity and
Okay, can you see that again,
things you have
guys?
to work around. You are back. You are not in presenter mode. You're in the
Okay.
but you just need to hit the presentation mode.
How about now?
Yes, there we go. Perfect.
Okay, so hopefully it works. I stopped the timing. And again, right here, you could see we went back, and the vessel wall imaging being confirmed again, the intensity of the vessel wall imaging, the signal, if you will, correlate exactly with the number of inflammatory cells. And we devised a way, working with others, and how to quantify that intensity in the wall of the aneurysm. And you can see here, it's manual. We have to use 4 points and the pituitary stalk and 4 points in the aneurysm wall, quantified it, average it, and then, so it's a lot of bias there. So we decided to work like the heat map. Here, right here. Okay. And you can take the aneurysm and create a heat map, and because of that, you can actually create different colors that correlate with the intensity of the gadolinium taken by the aneurysm wall. And we also created a 3D presentation, because if you do a 2D, you cannot superimpose it, if you will, on the 3D created by the computational fluid dynamic. And I mean, this is what I show you now, like right here. So this is where we moved, and we looked at not only aneurysm wall tissue and the high resolution vessel wall imaging, we looked at all the computational fluid dynamic metrics, from ellipticity, sphericity, aneurysm ratio, all that. And also we created a hemodynamic analysis. And you look here, we have an aneurysm, and we look at it in many ways. 3D from angiogram, vessel wall imaging, you can see that little dot there. And we did CFD and finite wall element analysis. And we took many aneurysms. The guys in University of Washington, they do the same thing. And we wanted to, as a complement, a new tool to see if there is correlation. And behold, yes, we did. And when we found out that the enhancement of the aneurysm wall in the vessel wall imaging is not a true biomarker of inflammation. It's not. It is true biomarker of low wall shear stress, okay? And so it's exactly with those words. It's a biomarker of low wall shear stress. All these people that published thousands on these topics, they said it's a biomarker inflammation. It is not. It is a biomarker of low wall shear stress. But low wall shear stress in itself can lead to increased inflammation within the aneurysm wall. So it somehow became a surrogate biomarker, if you will. And confirmed that in multiple studies. We worked with a group in Germany and Zurich to validate that. The next step is, there's this, a hypothesis about, is there a difference, a microenvironment difference within the aneurysm wall that it's completely different than, let's say, the petrous segment of the carotid epsilon. So what we do here, we have like an envoy, 6 French envoy catheter. We put it up high in the petrous segment, and you can see the red in the microcatheter inside the dome of the aneurysm. And what we did is we collected blood from these two. It's really hard to aspirate through an SL10, but we were managed. We wait for about 10 minutes, kind of slowly sucking blood back. And we took all that, and we did what we call liquid biopsy, and compared the fluid inside, or the microenvironment inside the dome, versus the petrous segment. And this is what we found out. We did extensive workout. We did multi-omics. And what we found out that the microenvironment inside the aneurysm is truly different than the blood in the petrous segment. And we had about 6 papers published on that, including stroke, hypertension, ATV. But we also did the 360-degree analysis, where we just opened all these things they could use, from vessel wall imaging, CFD, finite element analysis, all the indices, all the cytokines. And what we found out that all these are correlated. So high vessel imaging, while it's a surrogate biomarker inflammation, it correlated really well with the aneurysm area, aneurysm volume, the maximum diameter, the flow, the non-sphericity index, which means deviation from being complete sphere to delta interleukin 10. And so for the first time, we used all these tools to show that the vessel wall imaging is truly a surrogate biomarker for inflammation. So we wanted to do a study, and that study is, again, we're going to go back to aspirin, We used originally the femoxytil, but it's black box. So we had to use a tool that now widely used, accessible. You can use it on a daily basis with patient and see if we can see the effect of aspirin. And so we did a longitudinal study, did not randomize, but patients were some on aspirin and some are not for one reason or another. And then we did a propensity score at the end. And we looked at different things. And what we found out that right here, if you look, aspirin, 81 milligram decrease the intensity of the vessel wall image over 6 months. So if we took all these patients, we imaged them with high resolution vessel wall imaging, we used the 3T, we created the 3D image of the vessel wall imaging like the heat map, and followed them for 6 months, and then looked at different changes, including age, sex, hypertension, and smoking, size and location, and other things, and then imaged them in 6 months. And so if the signal changed and how it's related. And what we found out that aspirin was the only agent or only variable, if you were, that decreases the intensity of the vessel wall imaging. The other ones either increased it or did not change. So this is our conclusion, that 81 milligram of aspirin for over 6 months significantly decreased wall enhancement. So now we can follow longitudinally the effect of aspirin and or hopefully another agent using an imaging technique which is accessible, easy. All we have to do is standardize it. So the next thing is, okay, how does aspirin work? So all this is great. All this is, amazing, if you will. But what's the mechanism? Because without the mechanism, it's still, you're really venturing into a cause and not a cause effect, but more an association. So we have to show that in mice. And this is what we adapted from Tomoki Hashimoto. He was at UCSF, but now he's in BNI after Michael Lawton moved there. And we adapted his model. We modified it a little bit. And we use aspirin, elastase, and angiotensin. And you can see here we use coordinate. We use stereotactic injection of elastase at the base, the skull base of the mice, and then put a mini pump to increase blood pressure. And this is the grading like Hunt and Hess for mice, if you will. Again, this is Tomoki's work. And we adapted. And look here, this is our model. You can see that with this way, we can form giant aneurysms in mice. Some goes to rupture, like on the left, and some, stays non-rupture. So it can somehow create or mimic again the gate, not exactly, but mimic aneurysm in humans. So we use that model, and we showed that aspirin and COX-2 inhibitor, which, as we know, is it's one of the more specific inhibitors in the arachidonic pathway. And you can see only aspirin and COX-2 inhibitor that decrease the aneurysm rupture in mice. COX-1 inhibitor did not. And then we looked and says, okay, can the same observation stands or holds in mice like we did in human? So meaning, does the aspirin is only specific effect in male and not in female? And yes, we found that when we separated the male mice from the female mice, we saw that the aspirin effect only holds in male, not female. So we try to figure out why this happened. And again, we used the gunshot tablet technique. We looked at everything. We would throw a wide cast. And one of the things that completely looked different between male and female is 15 PGDH. Okay, this an enzyme, if you will, down in the pathway for arachidonic acid. So what we did, we went to the male mice and gave them aspirin. You can see here it's decreased by 20%, and the female with aspirin. But we added an inhibitor for this enzyme in males and an activator in female. And once you do that, you could see here, if you compare male aspirin to male aspirin inhibitor, that effect of the aspirin was obliterated. And if you add the activator to the female, then the female in itself, they were much better responder than the males. And we went and we did the same thing, but this time not with aspirin. What we use is 15-PGDH, either an agonist or antagonist. So we wanted to see with agonist first. And we did male mice and female mice. And behold, if you activate 15-PGDH, then both male and female will respond equally, and they have a decreased risk of aneurysm rupture. So for the first time, we were able to identify an enzyme that could explain why the difference between male and female in terms of rupture. No one had published that before. And we took, again, the aneurysm wall tissue, stained it for 15-PGDH, and you could see right here, this is a female, that it's much less than male. We then went back to the liquid biopsy, like I explained to it, and we wanted to see, before we didn't look at this enzyme because we didn't know about it. So we went and looked specifically for this enzyme and to see if there's a difference between male and female. And behold, females have much less concentration of this aneurysm inside the dome of the aneurysm versus male, which confirms our finding. So we published that. I think it was in Stroke, I think, or JAHA. I can't remember which journal, but we published that in that. And then we went in and did extensive studies. I'm not going to bore you guys. And we showed in detail that 15-PGDH, which again, downstream from arachidonic acid, does indeed change the inflammatory effect. And because of that, it can modulate the inflammation in male and female equally, if you will. And so these are more, we looked also PPAR gamma, but this is the pathway that I'm going to show you here. As you can see here, aspirin works in COX-2, which is an enzyme that comes and modify arachidonic acid to different prostaglandins, including NBGH. But prostaglandin E2, which we also show that it's harmful, is the one that caused the aneurysm rupture. And the Japanese colleagues also confirmed that and published on it. So prostaglandin E2 and its receptor E2 are the ones that are responsible at the end product of causing this cascade, if you will. And 15-PGDH work right on prostaglandin E2 and it inhibit prostaglandin E2. But not only that, it converted to PPAR gamma, which we also showed that PPAR gamma itself is protective. So now we have 15-PGDH, and Pfizer has that. We're going to try to reach out to them. But can we do targeted molecular therapy using nanoparticles? Okay, so what we did, we took this formoxetol. As you know, it's iron oxide nanoparticles. And we went to chemistry and biochemistry, and we modified it. And we put on the surface is antibodies that only bind to elastin, fragmented elastin. You can see right here the rabbit anti-elastin in the corner. But also, we coated it with recombinant human 15-PGDH. And the idea was, if you let these nanoparticles circulate, they will only bind to the aneurysm wall because, as we know, there are fragmented elastin that are exposed, okay? So we wanted to see if this is coated modifying particles can bind that. Well, we found out that also it binds to the lungs because people who have emphysema, they have also exposed elastin. So it also can bind to the lung. But in human, No, I'm sorry, in human. Well, yes, ex vivo human, because we use STA, superficial temporal artery. So this is what we did. We took a harvested superficial temporal artery from humans during different surgeries, and we ligated both of them. But after we put elastin, and the elastin will do is digest and expose the internal elastic membrane. And then we incubated it with these nanoparticles that modify. And you could see right here, these nanoparticles are green, and you could see they're bind after we wash them. You can see they are binding to the elastin that is exposed inside the superficial temporal artery. And then we stained it, and you can see right here it's blue because it's iron oxide nanoparticle. So the idea now, we created nanoparticles that can be visualized and monitored and traced by tweaking the MRI sequences, but also therapeutic that could modify the aneurysm wall. So what we did here, we looked if these nanoparticles are effective, and what we found out, they do work. They do increase inflammation within the wall of the internal elastic, superficial temporal artery. So not only these nanoparticles can be traced radiographically, but they do have some therapeutic effect. We're still working on it. So, in short, I know it's a lot of slides, but again, the purpose is not to convince you again that the aspirin specifically change or anything, but more to introduce you to tools that neurosurgeons, endovascular people that could use and help advance the research in terms of aneurysms, AVMs, dural AV fistula. And so in conclusion, what we showed that aspirin does decrease the risk of aneurysm rupture, growth, and recurrence, and it's more in males than females. 15-PGDH is an enzyme that's only present or mostly present in males, not females. And because of that, the natural history is different between males and females. There's more rupture and more aneurysm formation in females than males, and we think because of this enzyme. And once you activate this enzyme both in male and female, then you can have equal effect, if you will. And because of all this, we can show that that medical treatment can halt aneurysm progression. What do I mean by that? If an aneurysm you come in the clinic, and because of advanced techniques and you complain of your toe hurt, you get an MRI of your brain, and behold, you have a 3-millimeter aneurysm. We discourage people from treating that, but we can use medical agent to prevent these aneurysms that are small or not a threat, and prevent them from growing in the future or rupture. So that's what we advocate. We don't advocate that if you have an aneurysm that's 7 millimeter to treat it with aspirin or 15-PGDH agonist. No, we don't recommend that at all. As I said, these small aneurysms that you end up only watching, instead of just watching with modifying lifestyles, like stop smoking, control blood pressure, and imaging, you can add an agent that hopefully halt the progression of these aneurysms. And the best way, we as neurosurgeon and endovascular, we can really play a critical role, like as simple as going in, putting the catheter, and aspirating the blood, whether from aneurysms. You can do that for AVMs. You can do it for fistula or whatever the disease. An example like now, we do for sinus stenosis, transverse sinus stenosis. We put the catheter in the pittress ICA segment, and as you know, you have a catheter in the jugular bolt. We collect the blood from both sides, and we're looking to see the effect. We are helping our colleague from anesthesia to look at the effect of different anesthetic agent, like propofol versus Sevo and how that affect post-operative delay. So we, as neurosurgeon, again, and endovascular, can play major role on different things. And I just kind of tell you, one of the things we also did develop, which right here, guys, you can see it. Okay, that also you guys can do. We heard about this is a little just deviation on the topic, but again, I'm trying to push as many of our colleagues to go into this. We heard about the stint road. We heard about Elon Musk, but this is a web device that we used. I'm just going to tell you here. And what we did, we put it in the aneurysm, and we before detach it, we connected to an EEG monitors, and we did testing to test it specifically for gyrus rectus, and and kind of gambling well, and you can see right here, and like we see the device, but we start recording from the web device, and we were able to capture signal that is specific to task, specific in gyrus rectus. And you could see here, after we took the pulsation from it, you can actually record the activity that elicited it by just activating gyrus rectus. And you can see right here. And we published on 17 patients. It was published in GNS. But again, you can use that now. We're trying to use it for stimulation. We found out that in monkeys, we did that in monkeys, that if you stimulate Brodmann area 25, you decrease the blood pressure. So we developed a stent that is wireless, and it works based on the flow, so a closed loop, that we're going to try to do it in monkey. We did it in baboons, and it's promising results. So here we are. This is all the work cannot be done by myself. There's several people who helped with that. With that, I stop and stop sharing. So again, please understand that my goal today is to encourage you guys to be active, and you can make a difference. You don't ever think that, oh, because I haven't done research, I can't do anything. You actually can, and you have the tools that helps all these PhDs to do their work. Thanks.
Great. Thank you so much, Dr. Hasan, for this great, insightful talk. We'll open the floor now to the questions.
That really was a wonderful sort of story that you tell. You make it a great sort of detective adventure. Actually, with Steve, you have your hand up. Why don't you go ahead?
Thanks, Cameron. Thanks, David. That was awesome. Great to see you again, and it's been a real privilege following your career with this topic and seeing how it's evolved over more than a decade of this huge amount of work. It's been fascinating. So from a practical standpoint, when you see patients in the office, in terms of your sort of applicability, do you put everyone on aspirin? Do you put them on high-dose aspirin? What do you do when you see men and women in the clinic? Do you treat them differently than, say, your colleagues do? Or from a practical standpoint, how have you kind of modified your practice?
That's a very good question, Steve. And again, it's good to see you, friend. I'm trying to be very specific. Again, aneurysm, from all the ISO data and others, the Chinese and all these studies, did not show that aspirin increased the risk of rupture. It did not. Now, does aspirin worsen functional outcome after the rupture? So let's say you're on aspirin and the aneurysm rupture. Well, automatically, that's what Northwestern did. Hunt Pager and Bindock looked at that after we came up with this idea. And from their series, they found out that yes, the amount of blood, let's say you were on aspirin and the aneurysm rupture, for one reason or another. The amount of blood is higher in this group, but they looked at the functional outcome and they saw the functional outcome is no different. The same thing as in an ISOA. And so because of that, I modified my practice, and quite a few people did, mainly in Europe and the Chinese and others, where we only recommend aspirin is if the aneurysm is small, 3-4 millimeter, sometimes 5 millimeters, and you elect with discussion with the patient to follow it longitudinally. So we add in aspirin to this group. We do not recommend aspirin for people who have large aneurysm or have increased risk of rupture, if you will. We actually recommend treatment. Now, in terms of male and female, at this point, there is no an active agent that equally affect male and female. So I do tell them that upfront that aspirin is more effective in male than female. You're welcome. If it's a female, you're welcome to take it. If not, I understand. This data was validated, okay, guys, in colon cancer. There's a subtype of colon cancer that is responsive to aspirin, high dose of aspirin. And what they found out too, that the reason of that is 15 PGDH. And that's why the aspirin, if you take it, they recommend a subtype of colon cancer. So we're hoping that we're moving forward with trying to use one of the agents that's been approved, or at least phase 1, to advance it. And honestly, if you ask me 20 years from now, we all gonna laugh, and it's like, oh my gosh, we're archaic. Now we used to put coils in aneurysms. I really think 20, 30 years, we're gonna start treating aneurysms with nanoparticles that can go in and bind to aneurysm wall selectively, like I showed you, and modify the wall. That's my vision, 20, 30 years. We start working on that, as I showed you. It's going to take time, but it's happening. I mean, if you asked us 30 years, I'm not trying to say Dr. McDougall is still very young, but if you asked him 30 years ago, 40 years ago, with coiling, web device, and flow diverter will be the way of treatment, he probably, being a visionary guy, he probably said yes. I would say no. And a lot of dinosaurs, they fought it hard, but
I did kind of bet on that.
But you know what I'm saying? I mean, you gotta have to be open mind and visionary, look forward. And most of anything, guys, we are venturing. The guys at Stentrode, they put in using the stent as PCI, brain computer interface, for recording. And we showed that we can record intraarterial, you're just using the web device. And also we went in, when we do the water testing, I would go in and put the solitaire in the PCA, and we do recording from scalp recording and from the solitaire. And it's the signal from the solitaire in the PCA, because it's kind of up the hippocampus and the amygdala, is a better signal
Yeah, that's
than
very cool.
So we, as a neurosurgeon endovascular, the field is the beginning. We're going to be in the PCI world in it, and instead of just putting electrode or DBSs, So we're going to modify the field. That's my enthusiasm.
No, that's a great vision. I want to ask you about dolichoectatic aneurysms, if they aren't perhaps a very sort of rich target for some of your elastase modifications, and maybe a real place to sort of a desperate case patient population for a really unsolved problem. What do you think about those aneurysms? What's that environment like in view of this PGDH and inflammation?
Doug, it's a very good question. We cannot study it because, as you know, the fusiform aneurysms, especially the big ones, and that do brainstem compression or other, I maybe see one a year or 2 a year. So it doesn't have enough data we do to really tell you comfortably how is it different. We think, we hypothesize that that's aneurysm are different animals, literally completely different animals than the saccular aneurysms. We know they're rich in inflammation. We try to extrapolate from the aortic aneurysms to them because we think they're similar type. How are we going to modify them? Like you said, that it's still out there. I think, again, I don't have a proof. I haven't studied it, but I think maybe aspirin or some other agents could play a role in it.
Is there an opportunity there to sort of set up a repository for even just the liquid biopsy in those patients?
Yeah, there's a huge opportunity in all of these targets, if you will. And if we can do a registry, someone leads it, and especially I'm talking here to the young guys, because remember that I would tell you, and Doug knows probably, when I was in residency, I only had one publication, to be honest with you, just one publication. All this became because when you're an academic, you become curious. So it's a huge opportunity for the younger people to take on topics like Dr. McDougall's about, fusiform aneurysm, and get the group, us, Duke, and others to help you. I'm happy to collect blood samples for you. Sometimes the guys in UCS have talked about going with, with the microwire.
Scraping the wall.
Yeah, scraping the wall. But we're not successful. What we use is sometimes when we have the stent retriever, because sometimes I would call it the stent retriever, as I drag it down, I can collect more endothelial cells. But that's very, very rare. So there's a lot of opportunities there. But it's a good question because this group of patients are, stumps everybody. The only thing they have left either do 5-6 flow diverters or do like Michael Lawton do, is to clip everything and bypass the whole body, and hopefully they wake up if they wake up. Yeah. I didn't say that. Please don't repeat it.
There are a lot of those. We do see a reasonable number of those patients. So it's still a very small number, but before they have their mass effect, we see clearly the vessel is moving in that direction, but they haven't yet got the mass effect. And so in terms of a medication that reduces the vessel wall inflammation, the PGDH agonist or something, if you're creating a medicine, testing it, looking for places, that might be a small group of people who we do know there's a higher number that progress, that sort of thing.
So let me tell you, this is not my idea. This is Mark Summer from Maryland. Doug probably knows him. He creatively looked at, and his idea came from, with AVM, sometimes they have internodal aneurysms, and we do a stereotactic radiosurgery. Does the stereotactic radiosurgery increase the risk of aneurysm rupture or not in these? Anyone guessed? And by now you should know I'm trying to trick you. So what he did, he looked at it in rabbits and created aneurysms like the last days model that the Mayo Clinic developed. And he did the stereotactic radiosurgery for all these aneurysms. And published that. And he found out that these gamma knives really increase the thickness of the wall. So it's more protective. So Doug, to your question is, can we use stereotactic radiosurgery for these giant atherosclerotic fusiform aneurysm and thicken the wall? Because the way they work in AVMs, they injure the intima, and then the intima thickens and closes. And so the question is, can we do that? I try to do it in Iowa, where I went to the IRB, and I said, listen, all these cavernous aneurysms We watch them. And so can I go in and do stereotactic radiosurgery? And what's the worst can happen? If a rupture, they don't kill, they just cause a fistula and treat it. No one will buy on it. But that's an opportunity. It's published in Rapid, and I tried hard to translate it to human. He tried to do that in human, and it hasn't been successful. We did in mice similar, but we did a whole brain radiation, and we found out it's also protective.
Tough sell, though.
Yeah.
Yeah. All right. We've taken up enough of your time this morning. I learned a lot. I enjoyed it. I enjoyed spending time with you. Really appreciate you sharing it with us. So thanks so much, and congratulations on a long track of great work.
Thank you, guys. You guys have an amazing program.